Hello and good day. So today we're going to talk about your final stretch. It's going to be the renal system for your critical care nursing. And last time I've already posted to you about the anatomy and physiology of our renal system. And I hope it's already easier for you to understand this kind of concept. It's because you're already in your fourth year level. And most probably, you already met or encountered this kind of terms that we're going to talk during this course of lecture. And for the first time that we're going to discuss, it's all about your acute renal failure. So, in your acute renal failure, it is also known as your acute uh, kidney injury. Now, what is happening here is that there is a sudden decrease or cessation of your renal function. And what is happening is that the kidneys were not able to filter the blood, which results to build up of water and any other waste products in our body. And we all know that if there are waste products that are increase in terms of number in our body, it's not going to be beneficial on our part. So this is a very common clinical syndrome in which there is a sudden onset of reduced renal function that can result in derangement in terms of your fluid and electrolyte balance. It also has a problem in terms of the acid-base homeostasis, your calcium phosphate metabolism, as well as the blood pressure regulation, and of course your erythropoiesis. Okay, now moving on here on this next part, what is happening here is that your kidneys have the tiny filters, which is what we call as your glomeruli. Am I right? Yes. Okay, now your glomeruli, these filters will help remove waste and then excess fluid from the blood. This is what we've learned um, in your renal system. Okay. Now we also have here on this part your GFR, your glomerular filtration rate. Now this actually tests or estimates how much blood passes through these filters each minute. Now, of course, if you have depreciated GFR, of course, there's going to be less blood that can be filtered in our renal system. Now, the key difference between your uremia here and also your azotemia, as you can see here, it's because there's going to be a reflected by an accumulation of blood urea nitrogen, your BUN. These are the cardinal or the manifestations of your renal problem. There's going to be an elevation of your BUN. There's going to be a serum creatinine, a condition termed as your azotemia. Now, your azotemia and your uremia, most often than not, they're being interchanged. Now, the difference is that uremia is a kidney condition that occurs when there is a high urea content in the blood. Okay, that's your uremia. There's going to be a um, high urea content in the blood, while your azotemia here, it is a kidney condition that occurs there is a high nitrogen content in the blood. So um, that's the two most or the key difference between these two disorder. Now your creatinine is better marker. It is relatively unaffected by your metabolic factors. Now let's move on here to the next one. So in terms of your acute renal failure, the causes of this one is we have what we term as your pre-renal, your physiological event that results in I mean your hypoperfusion, hypovolemia, cardiovascular failure, as well as your sepsis. Now, if you're going to look closely here in this diagram, what is happening here is that any damage that are located or happen before the kidney. It means that the damage is not in the kidney itself, it's before the kidney. Remember that the heart helps the kidney with regards to the blood flow. Now, if there are cardio problems, perfusion, of course, will arise, which can decrease the function of the kidney. Now, with the low blood entering the kidney, little blood will be filtered. So it's going to be a problem. So that's the basic uh, description about your pre-renal in terms of the causes of your ARF. Now let's move on. How about your intra-renal? From the term itself, intra, it means it's already inside. So there's going to be an actual damage to your renal parenchyma. Okay. Now, so again, intrarenal itself, it's from the inside, specifically in your nephrons. Now, because of the damages happening on the structures here inside the kidney, it will be the blood flow, it will not be able to filter blood properly. Now, having said that, there will be an increase in terms of your water retention as well as decrease in the removal of your waste products and imbalance, of course, of your electrolytes. And mostly the main cause of your nephrotoxic medications such as your NSAIDs, your chemo drugs, high-level antibiotics, your glycosides, as well as the contrast that is being used in your laboratory test. Okay, infection as well will be a factor here in terms of your intrarenal. But what you're going to remember here are the medications where they are very toxic and they can easily affect your kidneys. Again, such as your NSAIDs, your chemo drugs, high-level antibiotics. These medications you've already encountered this one in your pharmacology subject as well as on your duty if you're already having your duty in dialysis area. Okay, now let's move on here. So how about your post-renal? Now, any obstruction in the blood flow of urine from the collecting ducts in the internal and external urethral orifice. Now, as you can see here in this structure, there's already a blockage. There's already a obstruction in which it limits the natural flow of urine coming out to your urethra or coming out to your uh, that can be removed from our body. Now, on this space, there's already a blockage, and which eventually hinders the expulsion of the waste products. It can increase as well the pressure on the kidney because of the blockage. So what's happening here? If there's a pressure here, of course, there's going to be regurgitation. There's going to be a backflow and retention of waste product that naturally it should go out in our body, but it will go back. It's because of the blockage. Now that is what we term as your post-renal. Okay, now let's go back here. How about your acute renal failure in terms of onset phase? Now what is happening here is this is the initiation or the start of the stage. This is the best time to detect the cause of your AKI so that it will not progress to worse conditions. Okay, so this is the time that if you are feeling something that is wrong or there are manifestations already coming from your inside of your body, this is the time for you to have uh, how do you call this, consultations with your doctor. You have to check your BUN or your kidney itself. Okay, so on the onset phase, common triggering events like significant blood loss, there's going to be burns, fluid loss, and also diabetes insipidus. Renal blood flow 25% of normal, tissue oxygenation 25%, and the urine output is 0.5 ml per kilogram per hour. Okay, moving on to the next part, which is your oligoric. Oligoric or non-oligoric phase is that what is happening here in this stage is that it can actually be skipped and it will progress immediately to your diuresis stage. So there are patients who can actually not experiencing your oligoric or non-oligoric phase. So from the onset, they can go directly to your diuresis stage. Okay. However, there are still patients who are undergoing this kind of stage. Now, you are all familiar with oliguria. I know that you know this term already. This is a condition with urine output of less than 400 ml per day. Now, this is due, of course, with the decrease in terms of your GFR. In consonance to the decrease of your GFR, your BUN and CREA will be elevated, and most of them will become sleepy, tired, and a bit confused. This is one of the this is some of the things that the patients who are experiencing, um, you know, increase in terms of your BUN and CREA and decrease GFR. So what you should do here as a student nurse is to provide safety. It's because the patient is sleepy, tired, and a little bit confused. And you've learned this one already during your bedside care to your patient that you need to elevate or raise the side rails of the client. You need to assist them whenever they wanted to go outside of the bed and anything that makes the patient safe. Okay, complications for these are your, or for this one is your hyperkalemia. Now, we all know that hyperkalemia can cause your cardiac issues, and most likely your attending physicians will order your K-Exalate. Now, your K-Exalate with this one, it's a good medication to combat your um, hyperkalemia. But what you're going to do here, as well as student nurses, is to check the ECG of the client. Okay, aside from checking the ECG of the client, you also need to check the laboratories of our patients. Okay, now let's go here. Again, your non-oliguric phase or oliguric phase, it can be skipped and patients can go directly from onset to your diuretic phase. Now, in your diuretic phase, this can last from 1 to 2 weeks, characterized by a gradual increase in the urine output as renal function starts to resume. Now, fluid volume deficits and electrolytes abnormalities can actually happen here. It's because there's going to be a normal urine output already. Okay, or most often than not, increase in terms of renal function or urine output. So what you're going to check what you're going to check here is fluid volume deficits, the manifestations, dehydration. You have to check the skin turgor of the clients as well as the ECG. Now, the goals here as a student nurse is to have to hydrate your patient, to ask the patient to drink water as tolerated, as well as prevention of electrolyte depletion and continued support of your renal function. Okay, I hope everything is well and we can move on here to the last phase, which is your recovery phase. What is happening here? This is the last it can actually last from several months to a year, and this will return to normal or near normal levels. And what you can do here, student nurses, is to reinforce patient education. Okay, every time whenever they be having a checkup or they're about to go home, you have to educate the client about the effects of. Okay, so we are done with your acute kidney disease, and this time we're going to talk about your chronic kidney disease. Now, what is happening here? There is a slow and progressive, irreversible deterioration in the renal function. Now, from the term itself, you're going to dissect it one by one. It is slow and progressive. It is also irreversible deterioration in terms of the renal function. Now, the results in the kidney's inability to eliminate waste products and maintain fluids and electrolyte balance. It also leads to the end-stage renal disease, or what we term as your ESRD. And with this time, it needs renal replacement therapy or renal transplantation to sustain life, or sometimes it really needs to have your dialysis. The causes of this one, most common is your diabetes mellitus as well as your hypertension. Now, this is what will happen during your kidney transplantation, that they're going to incise a live and healthy kidney, and then they're going to transfer that one to the patient. Okay. Most often than that, I think there's already some cases in which we had or we undergone in the regional medical center. So I think it's still ongoing right now in terms of kidney transplant. Now let's go here. This is your diabetic nephropathy. And what you're going to remember here is that in a nutshell, this is a condition which is irreversible. And mostly there are damages on your GFR and nephrons. Again, if there are issues here, blood filtration, waste products, water, and other will have imbalances. Okay. And moving on here to the next part, these are your chronic kidney disease. A while ago, we've mentioned to you your nephrotoxic drugs such as your NSAIDs, your high-level antibiotics, and glycosides. Other thing that we should do to prevent the progression of your CKD is to strict control of your blood glucose level, blood control also of your blood pressure, protein restriction diet, as well as your malnutrition. If you're going to see here in illustration, we have here some drug-induced kidney disease. Please do not overdose or overuse your medication with this one. It's because it will greatly affect your kidney functions. Now let's go here. Management. Mostly here, patients will be receiving diuretics, specifically your furosemide. Now, what is your furosemide? It is your loop diuretic medication used to treat the fluid buildup due to kidney disease. Others, it can be due to liver scarring or heart failure. But in our topic in your CCN renal, this is being used primarily it's because of the buildup in your kidney diseases. Okay, complications will have electrolyte imbalances, autotoxicity. We also have your dopamine. This is a renal vasodilation at renal doses, 1 to 3 mg per kilogram per minute, increasing renal perfusion. And of course, if there's going to be an increased renal perfusion, there's going to be a better excrement of waste products in our body. Now, fluid here, managing the fluid imbalance is fluid balance changes in chronic kidney restriction of your fluid. It should not be exceeding to 1.5 to 2 ml per day. So we can limit actually to at least 500 cc. And then salt restriction to 2,400 milligram per day. You already know what's with salt. And also your diuretics. And always remember to monitor your INO here as well as the weight of the patient. Management in terms of renal failure, alkaline medications, dialysis, or both. We also have your sodium bicarbonate IV for severe cases, or sometimes buffer for patients who are undergoing your hemodialysis. What is with your bicarbonate? It is a substance called as the base, which the body needs to help keep the normal acid base or the pH balance of their client. Okay, now let's move on here. How about the other management? Managing your cardiovascular alterations, hypertension. These are just good to know. They're just good to read. Let's move on here. Management of renal failure, your cardiovascular disease, hyperkalemia. What you're going to do here if the patient is having hyperkalemia, we already mentioned to you your K-Exolate a while ago. It's a medication that can actually combat your hyperkalemia. And what you're going to check here is the ECG of the client. Supposed to be there's going to be a tall, tented T waves and prolonged PR interval here, and loss of the P wave and widening in your QRS complex. Okay, so the IV calcium gluconate, IV insulin, and IV dextrose administration to remove the potassium from the body. Management. How about this one? Pericarditis. I think we've mentioned this one already in our cardiovascular disease. This is resulting from your uremia. Patient can actually feel chest pain, fever, pericardial friction rub, the classic triad in which we've already discussed before. So what is happening here is actually the pericardium actually isn't essential for the normal heart function. It will not affect the normal function of our body. So it's okay if we're going to remove the one. Now, removing your pericardium doesn't cause any problem as long as your lungs and your diaphragm are intact. Okay, if you have pericarditis, your pericardium already has lost its lubricating ability. and removing it doesn't make that worse. Okay, now let's move on here to the next one. Your pulmonary edema, we also discussed this one already in your respiratory disease. So just go back to that topic and, revisit what we have discussed about this one. And here, how about bleeding? So mostly it's because patients who are undergoing dialysis are having problems in terms of GI bleed that is brought to you by your kidney as well. So just read this part here. Yeah. And most often than not, anemia, if there's like erythropoietin deficiency, there's going to be a decrease in terms of your red blood cell survival time and blood loss from an increased bleeding tendency. 90% of your erythropoietin is produced in the kidneys and your glycoprotein that stimulates your RBC production. Okay, how about this one? Hemodialysis. So I know that some of you here are already exposed in hemodialysis units of some of some hospitals that we are accredited with. So you have you already had the chance to at least assist patients undergoing hemodialysis. So what's important here is we have your dialyzer. It is the artificial kidney who will filter the blood so that we can remove the waste products in our body. So in a summary here, it removes the byproducts of protein metabolism, such as your urea, your creatinine, uric acid. It also removes excess water, maintains or restores the blood or the body's buffer system, and maintains or restores electrolyte levels in the body. Hemodialysis here, we also have here the complications. Just read these parts. I know you guys are very familiar with this one already. We also have your what we term as your peritoneal dialysis, where in the peritoneum, the semi-permeable membrane and osmosis is used to remove fluid rather than the pressure differentials used in your hemodialysis. The advantages of this one is the equipment and supplies are less complicated and are more readily available. Less training required as well, minimal adverse effect, and patient can learn to manage their own peritoneal dialysis at home. Disadvantages, you can just read this part on your PPT. And I think that's it for your CCN in terms of your renal system. What you're just going to remember here are the medications that are being used, or the medications that are nephrotoxic in terms or for our body. So that is for now. I wish you all the best for your finals, and I'll see you again next time. So thank you and have a great day.